My name is Trevor Cano, and I'm the Director of Special Events in NYU Alumni Relations. On behalf of our NYU alumni team, I want to thank you for joining us for today's webinar, COVID-19 in Perspective, When Epidemics Wreaked Havoc in America, presented by the NYU Alumni Association and the Department of History. Now, before we begin, please know that all of us at NYU hope you and your family are safe and well in these unprecedented times. And in light of the current global crisis, we have moved our programming online and are thankful you have chosen to join us and continue learning from the collective knowledge of our NYU community. The NYU Alumni Association represents over 500,000 alumni all over the world. On average, we host nearly 700 events annually to connect you with your alumni community. Make sure to check the NYU Alumni website and social media platforms to keep up to date with all our events and programs. If you have any questions during today's program, please enter them in the question and answer box on your Zoom screen. We will get to as many questions as we can at the end of the program. Thank you again for joining us. Now, I'm delighted to introduce Edward Berenson, Department Chair and Professor of History, who will introduce tonight's featured speaker, Professor David Oshinsky. Ed, take it away.
Hi, can you see it? There I am. Thank you, Trevor. Welcome, everybody. I'm thrilled that you all tuned in tonight, and welcome to the first history webinar for the academic year 2020-21. The topic couldn't be more timely, which of course is why we chose it. But beyond the subject of disease and epidemics, much of what we do in the NYU History Department deepens and enriches our understanding of the contemporary world. Our next history webinar on December 3rd, in that webinar, Professor Kimberly Phillips-Fine will compare New York City's fiscal crisis of the 1970s with the fiscal crisis the city faces today. Professor Stephen Hahn, who's our other Pulitzer Prize winner besides David Oshinsky, Steve Hahn, in his work, investigated the 19th century origins of the modern struggle for civil rights. Hasia Diener, another of our distinguished faculty members, has written about the centuries-long history of immigration to the United States. And these are just a few examples among many. Now, turning now to our students and you, our alumni, we're proud that we've helped launch many of you into distinguished careers. And we're gratified that we've placed a great many of our PhD graduates in top university positions. But the academic job market right now is extraordinarily difficult. And so one of our goals in this moment is to prepare our MA and PhD graduates for careers outside the academy, careers in which they can use their expert knowledge and research skills for this new endeavor. And so we're eager in this effort to benefit from your experience, your advice, and your financial support. And so if you're interested in hearing more about the work of the historians in our department, which is really one of the best history departments in the country, and if you're also interested in hearing about our expanding pedagogical goals, I invite you to join the NYU Friends of History. And in the chat, you'll find a link to the Friends. And now I'm thrilled to introduce my colleague and friend, David Oshinsky, who is a professor of history and director of the Division of Medical Humanities at NYU Langone Health. David Oshinsky is the author of too many distinguished books, and he's won too many prizes for me to be able to mention all of them now. I'll just note a few, beginning with the one that earned him a Pulitzer Prize, Polio, An American Story, published in 2006. This wonderful book narrates the race to create a polio vaccine, and it examines how the fear of polio shaped post-war American life. David Oshinsky's other remarkable books include Worse Than Slavery, which was awarded the Robert Kennedy Prize for its distinguished contribution to human rights, and the book Bellevue, 3 Centuries of Medicine and Mayhem at America's Most Storied Hospital. Bellevue won the Best Book of the Year awarded by NPR. You can also, and I'm sure you have read David's articles and columns in the New York Times, the Wall Street Journal, the New York Review of Books, and many other publications. And I'm proud now to present to you David Oshinsky.
Thank you, Ed. Thank you so much for that warm introduction. Welcome, everybody. I know we're in very anxious times and a pandemic is at our door, and we are dealing with it. And I'll try to talk about that a little bit at the end, how it sort of fits in with previous pandemics and what the future may hold for that. One of the things that I think you'll find especially interesting is that when you walk the ground on Washington Square, that is the burial ground for thousands upon thousands of epidemic victims, most of whom died during the great yellow fever epidemics of the 1790s in New York City. And there were so many deaths that they basically just took the bodies and dumped them and then covered them with lime. And as some of you may know, every time we do construction in Washington Square, we have to be very careful not to upset many of the graves that are buried underneath. What had happened that time in New York City in the 1790s, the vast majority of the city was down at the Battery where the Staten Island Ferry is now. And they basically had to find a burial ground that was far enough from the city. And basically Washington Square was countryside at this time because they believed that the bodies themselves, even dead bodies, could cause disease. And Bellevue Hospital, which is about another 2 miles further north on the East River at what is now 26th Street, Bellevue Hospital really came into being at that time as kind of a pest house or a death house for yellow fever victims. Yellow fever was devastating at this time. It came up from the West Indies. It came basically with mosquitoes in barrels. It hit Baltimore. It hit Philadelphia so hard that, as some of you may know, Philadelphia was our first capital. And Washington and Jefferson just basically took off and went to Virginia, and Congress closed down for a while because of the epidemic. So we have been in New York City as one of the great immigrant centers, the great harbor, a commercial center. We've been a center for disease and maladies going back centuries. And what I'd like to do is just to, with the exception, moving on from yellow fever, is just to talk very, very briefly about some of them, what was done, what progress was made, and basically how they kind of in some ways led to where we are today. Many of them had very positive outcomes, and I am cautiously optimistic as a vaccine is coming around the corner that if we really seriously get back to non-therapeutic measures in dealing with COVID, we can kind of buy some time between now and when the vaccine arrives. So Trevor, could you bring up the first slide, please? This is an interesting slide. This is Bellevue Hospital around 1840. That's the East River. And you can see the hospital is a very large facility at that time. At that time, the basic way of dealing with patients would be to bleed them and purge them. There was a belief in what was called the miasma theory, which was that disease was caused by these clouds that were filled with the dirt from cemeteries, the gas coming from various swamps and the like, and these would descend upon various areas and bring disease with them. What you see at Bellevue at this time, even as early as about 1840, is they do have quarantine tents. And these tents were for a disease called typhus, which is caused by a body louse. It's a bacterial disease, very, very deadly at that time, and probably brought by immigrants, particularly Irish immigrants, escaping the great famines of the 1830s and 40s. Trevor, can you move on to the next one, please? This is a really interesting, I think, depiction here. In the 1830s, 40s, and 50s, New York City was hit very, very hard by a disease known as cholera. It's a waterborne bacterial disease, but it's a disease that really tricks the body into excreting all of its liquid, so that you have explosive diarrhea, all kinds of vomiting, and you can be fine in the morning and you can be dead at night simply because you lose so many bodily fluids and your organs close down. One of the things that came out of the great cholera epidemics of this era was Croton water. In other words, New York City at this time basically got its water from the East River, from the Hudson River. What was now Canal Street was there in the 1830s and 40s, and basically was a canal in which refuse would flow in both directions into the East River and the Hudson. Most people got their water from very shallow wells, which were easily polluted by fecal matter. And what comes out of the great cholera epidemics is that New York City spends millions of dollars at this time and hires thousands and thousands of workers, particularly immigrant workers, to build this enormous aqueduct that will bring water from Westchester and the areas north of New York City through these aqueducts into great holding ponds in New York City. And the two biggest holding ponds were, one, the Central Park Reservoir, which is kind of still there. We don't use it as a reservoir, but people jog around it, as you know. And there was a giant reservoir in Bryant Park, where the New York Public Library is now. And what is so extraordinary about this depiction is that we still get much of our water the same way through the same aqueducts from the Croton Reservoir and reservoirs and rivers north of New York City. So what you can see basically in terms of cholera is that we did make enormous progress. We understood eventually what caused the disease. Miasma sort of gave way to what we call germ theory, where a specific microbe, an invisible microbe, caused a specific disease. And once we got a handle on that, we realized that basically we had to clean the city dramatically, and getting clean water was absolutely essential. And the water that they got then is basically, in many ways, the same water that we use today. And New York City water, as you know, wins all kinds of awards in terms of taste and quality and the like. Next slide, please. Many of you may have heard the term Typhoid Mary. When I was growing up as a baby boomer, when you wanted to stay away from someone, male or female, so that person's a Typhoid Mary, I must keep my distance. Typhoid Mary was a cook, an Irish cook. Her name was Mary Mallon, and she was an immigrant, unmarried, and she worked as a cook for many of the richer families in New York City. And it appeared that everywhere she cooked, people began to come down with typhoid fever. Again, a bacterial disease. It's not typhus, but it is very, very deadly. And she would cook. She seemed to be a very, very good cook, but there was a problem. And the problem was that the people she cooked for often got very sick and sometimes died. One of the wealthy families hired a detective, what we would call today an epidemiologist, to kind of figure out where this disease was coming from. And Mary seemed to be the central figure. She was arrested. She was brought before the Board of Health, and studies were done which showed that her body was filled with the bacillus from typhoid fever. The problem was with Mary, and that is interesting today with COVID, is that she was, as far as we know, the first documented silent carrier, the first inapparent carrier of disease, meaning that Mary Mallon had the disease, could super spread the disease, but felt no symptoms of the disease, very much like COVID today. To make a long story short, Mary Mallon was given a second chance. And what happened was that she was told never to cook again, to find another profession, and basically let go. And about 4 or 5 years later, there was another outbreak in a hospital in Manhattan of typhoid fever. And there was Mary Mallon cooking under an assumed name in anonymity. This time she was arrested and she was quarantined for the rest of her life, almost 3 decades, on an island in the East River. And thus the term Typhoid Mary. If Typhoid Mary had been a male cook, if she had been a man and married and supported a family, she may well have been treated differently. If she weren't an immigrant, she may well have been treated differently. There's sort of a big historical battle going on about Mary at this particular point. But what we do know is that although she showed no symptoms herself, she was a super spreader of the disease and basically the first documented case. Next slide, please. Okay, what I want to do now is to get to, obviously, the disease that basically in some ways is closest to COVID-19, and that is the great influenza of 1918, 1919. As some of you may know, it killed anywhere from 50 to 80 million people worldwide. Indeed, excuse me, it killed more people in a shorter period of time than any event in human history. It's absolutely extraordinary. Where did it begin? Everyone calls it the Spanish influenza. And I think that's sort of a slur on Spain. It really did not begin in Spain. It may have begun in an army base in Kansas. It may have begun in China. We really don't know. But the reason it was called the Spanish flu is that Spain was not a participant in World War I. It was neutral, and World War I was raging at this time. And therefore, Spain had no censorship in the press. In the United States, we were not writing much about, in the newspapers, about this unbelievable killer, this influenza, because the government was censoring all news that might make our enemies in the war think that we were on the verge of defeat. So England, which was in the war, Germany, which was in the war, United States in the war, none of us talked much about this disease. Spain did, and Spain actually paid a penalty, and that penalty was that it has now always had its name attributed to what really is the worst public health disaster in human history. Next slide, please. Here is Spanish influenza. And you can see that there, the other one was about a milkman. Here is don't spit. What is interesting about, there's several things that are very interesting about the so-called Spanish influenza. One was that unlike ordinary influenza, and to some degree, unlike COVID today, influenza in 1918, 1919 did not especially affect young children or the elderly. Indeed, the people who were most at risk for Spanish influenza were people, I think, of the age of most people who are listening to this, to my talk tonight, between the ages of 18 and 40. They were the ones who were getting it in the largest numbers and dying in the largest numbers. And at first everyone thought, well, it may be about World War I. There are a lot of soldiers, they're together very closely packed in army camps. They're at the front, they're not eating well, their immune systems may be run down. The problem was that the more we studied it, the more it was found out that women in the United States who were not in the service were getting it at basically the same rate and dying at basically the same rate. And male civilians of that same age who were not in the army were coming down with it at basically the same rate. So what caused it? What is the explanation if it wasn't the war? And the answer that most public health officials and doctors feel is something called cytokine storm. And what that means is that when an invader, a microbe, enters your body and you have never seen that microbe before, your immune system goes into overdrive to try to fight off that invader. And what you have in 1918, 1919 is that microbe is hitting everywhere, but those with the strongest immune systems put up the biggest battle against this unknown invader. And therefore your lungs if you're 18 to 40 and you're having a cytokine storm, if your immune system's in overdrive, your lungs are filled up with flotsam and mucus and dead cells. And what happens with the Great Spanish Influenza is that most people don't die of the flu. They die of bacterial pneumonia caused by the flu and caused by the cytokine storm. What else is, I think, particularly interesting about the Spanish influenza is the fact that there were no therapeutics. There was no vaccine. There were no steroids. There were no antibiotics to fight bacterial pneumonia. There were no antivirals. So what did they have? They had aspirin, they had whiskey. That's about it as far as a therapeutic. But what they really did have were non-therapeutic answers. For example, like mask wearing, like social distancing, like keeping crowds at basically the lowest levels possible, at staggering work hours so that the subways were not filled, with keeping windows open. And if you went to a theater, having a seat open between patrons, closing down schools, things like that. And what we found, there was a very, very large study done by a group of researchers, and it was published about a decade ago in the Journal of the American Medical Association, is that cities that began these kinds of lockdowns, and when it came to mask wearing, when it came to social distancing, when it came to doing away with parades, when it came to closing down non-essential businesses, cities that started the earliest and kept them in place the longest had by far the lowest mortality rates. So one of the things we have learned from the Spanish influenza is that non-therapeutic measures work. Social distancing works, masks work. They're not basically you need more. There was no vaccine, and in this case, the virus just had to burn itself out, and it did. What we will have besides non-therapeutic measures are certainly a vaccine, which will be coming, and I'll talk a bit about that a little bit later. But the point is that where we have used non-therapeutic measures in the United States and other parts of the world, we have seen that to some degree, we can keep COVID at bay. Next slide, please. This is the famous polio vaccine. Polio was a crippler of children. It was a virus. And there was no prevention, there was no cure, there was no vaccine. Poliovirus, wild poliovirus was circulating in the air. And if you just happen to be unlucky and you came down with it, you may well be paralyzed for life, like Franklin Roosevelt was paralyzed for life by polio. And you might actually, if you had a very serious case, you could die from polio. What is most interesting to me about polio was that the research battle and the public health battle against polio basically had no government intervention. The NIH was very small at this time. The CDC was barely getting started. There was no big pharma to speak of. But what you had were the American people sort of mobilizing. These were their children, and polio was like the crack in the middle class picture window of the 1940s and 1950s. And what you see are Americans like my parents joining the March of Dimes, raising money, going door to door, so that we can find researchers who will basically never give us the answer to polio. In other words, once you get polio, it is irreversible, but could find us vaccines for polio. And in the case of polio, we have two vaccines. They are still given today. One is a killed virus inactivated vaccine that's injected. One is a live virus vaccine that is given as a sugar cube or on the tongue. And what is extraordinary about these vaccines, among the fact that they work amazingly well and they're extremely safe, is that both were developed by NYU Medical School alums, Albert Sabin and of course Jonas Salk. as was basically the prevention for yellow fever by Walter Reed. You know, when President Trump went to Walter Reed Hospital, most people probably don't know who Walter Reed was. He was an NYU medical school graduate in the Army this was way before vaccines, but what Walter Reed figured out was what was the vector for yellow fever, and indeed it was a mosquito. So Walter Reed began screening windows, draining swamps, and doing those non-therapeutic measures that work dramatically to cut yellow fever down until we do have a vaccine. The final thing about polio is that it led to the largest public health experiment in American history. You know, we are finding now with phase 3 testing for COVID, we have about 30,000 people in a test. Almost 2 million school children were lined up across the country for the development of the polio vaccine. Half the kids were given a placebo, half the kids were given a live vaccine. This was before computers. It took a full year because it was a double-blind study to collate the paper, and it turned out the vaccine was safe, potent, and effective. And Jonas Salk was invited to the White House, where for the first time in anyone's memory, President Eisenhower broke down in tears as he thanked Jonas Salk for saving the children of America. Next slide, please. This is HIV. And what I'm showing you now, excuse me, is probably the first handwritten surveillance figures coming out of New York City in the early 1980s. And this was a disease, no one knew what it was, no one caused it. This is so early that KS stands for Kaposi sarcoma, a skin cancer, PCP for pneumocystis pneumonia. And these are from Bellevue Hospital. What was happening is that young men who seemed perfectly healthy were now coming in with these opportunistic infections that people at Bellevue hadn't seen for decades. And the reason was that they basically had HIV/AIDS, and their immune systems had been so desperately compromised that basically any disease that came down the pike was something they were likely to get. The reason I bring up AIDS is, number one, that it affected millions of people across the United States, but it really, in a sense, to me, is a disease in which there was social prejudice against certain groups, particularly gay men and intravenous drug users. Once it became clear how AIDS was transmitted, either through the blood or through semen, basically, you had people now who were saying, well, I'm not going to get AIDS. I practice safe sex. You had people from the evangelical right, like Jerry Falwell, who believed this was a sign from God, that America had become like Sodom and Gomorrah, and God was punishing evil people. What is extraordinary about AIDS is that you have to fight it on two fronts. You have to fight it on a medical front, and you also have to fight it on a social, cultural front. And it took a long time to do both. For example, in the early 1980s, you could not find a single, and I mean a single dentist in Manhattan who would treat an AIDS patient, indeed who would treat a gay man. If you were a young man and had some sort of episode in Washington Square Park, you were not going to get an EMS worker to give you CPR. It just wasn't done. There was such an enormous fear of this disease and the people who might be carrying it. What happens is that over time, these prejudices break down. And also over time, we begin to really get a handle on AIDS, how it's transmitted. It's a retrovirus, how you deal with it. And we still do not have a vaccine for AIDS. The reason being that unlike polio, the AIDS virus is always changing. It's ever changing, and therefore it's very, very hard to keep up with it in terms of a vaccine. But we do have antivirals now, literally, which are now one pill, which can get that HIV load down to 0. You have to keep taking the pill, and hopefully you will practice safe sex. But what did happen with AIDS, and also a lot of it happened at NYU and Bellevue, is that we had massive studies using antivirals, and we have reached the point now where AIDS has moved from being a death sentence to really being a manageable condition. And that is extraordinary. And that is some of, I think, the good feeling that we may have that we do progress medically, and at some point we will also have COVID under control, particularly with a vaccine. There are a couple things I want to finish with. I know I'm coming close to my my allotted time, but I do want to talk a bit about COVID. COVID is such now that we are in a position where we have a vaccine, we know the vaccine's coming. Until the vaccine does come, we really must practice non-therapeutic measures. But all kinds of questions are being raised now about the vaccine itself. If you look at sort of the Pew polls, fewer Americans each month feel confident about taking the vaccine. Some are worried that they may have to pay for it. Some don't think it's going to do much good. But mostly people are worried really about the safety of the vaccine. It's moving so quickly. Will it be safe? What does warp speed mean? They really, in a sense, don't understand the concept that what warp speed, what we are really talking about is giving lots of money to different companies, telling them that if the vaccine doesn't work, the US government will take the financial hit. And we are developing the vaccine at the same time we are testing the vaccine. We're doing those together, and that really is what warp speed means, which means if the testing is successful, the vaccine now will be there. It's simply a matter of trying to explain as best to the American people why you should take the vaccine. And there are all kinds of issues now, as I wrap up, involving mandates. Should we demand that certain groups take the vaccine? Which groups should go first? Should we give it to first responders and hospital workers? Should we then move to people with certain conditions? Should we give it to the elderly? How do we dole this vaccine out? And most important of all, as an anti-vaccine movement is growing, how do we explain to the American people that the vaccine is safe and effective, and that in taking the vaccine, you not only protect yourself, but you protect others around you? And what I think we've got to do in a way is to look back to history through cholera and influenza and polio and HIV, and realize that each step of the way we have made medical and social progress. And I think the same thing will happen to COVID. Now, I will say finally that, you know, bubbling up somewhere in a bat cave, in a wet market, maybe the next virus, maybe the next COVID. And nature is always one step ahead. We cannot be arrogant enough to feel that we have conquered infectious disease. But what we can do is to have faith in science, in our medical community, in our researchers, in our public health officials. And in doing so, I think we will basically see the end of this pandemic in hopefully a year's time or less. Thank you very much, and I am ready to take questions.
David, thank you. We have a whole bunch of questions, so let's get right to them. The first one is, isn't it true that the pandemic of 1918 died out in about 18 to 24 months? Could the same possibly happen with COVID-19?
The answer is yes. The difference is that you would need a sort of herd immunity. And the herd immunity now for COVID is probably about 10 to 15% at most. What happened is The questioner is absolutely correct. It did take close to 24 months, and there were 3 different waves of the med. The second wave being the worst. And what we found out is that those who actually got influenza in the first wave were largely immune when the second wave came around. The difference here was that so many people in the United States came down with influenza in 1918, 1919, that basically the virus ran out of hosts. And in the case of COVID, it would take a heck of a long time for that to happen. So I don't see COVID burning itself out. I don't see herd immunity reaching a level of, say, 70% without a vaccine.
So the corollary then is, you want to hazard a guess of when a vaccine, an effective vaccine, might be ready?
I would hazard a guess because NYU is testing the Pfizer vaccine. We do have about almost a dozen vaccines on the market from different platforms. I think that we will have a vaccine probably ready by early next year. What we don't know, Ed, is will it be the J&J vaccine or other, where you really have to keep it at an extraordinarily low temperature. So therefore it might have to be given only in certain places. Will you have to take more than 1 dose of this vaccine? And even more important, like the flu vaccine, will you have to take it every year? If we get these 2 doses, does that mean that it's gone? You'll be immunized from COVID forever. And the vaccine will probably be we're lucky if it'll be 60 or 70% effective, but we don't know any of these questions. How many shots will we have to take? Will we have to take it regularly every year? How effective will it be? Will it be equally effective among children and old people and those with pre-existing conditions? These are all questions that still have to be answered.
So a few questions about non-therapeutics for COVID. And so one is, what do you think about a national mandate, mask mandate? Is that something we should have?
I do believe it is something we should have. I think we should have it because by all studies that I have seen, it does save lives. What I fear now, and I don't want to get into politics, what I fear now is that non-mask wearing has sort of entered, has entered the political arena. And people are wearing it or not wearing it almost as a sign of where they stand politically and whom they support. And that to me is absolutely disastrous. So if you would have a situation where you would have a rally where 30,000 people showed up without masks, what do you do? I think what you can do is, if, let's say there were a change in administration, you could have a situation where science is taken more seriously, scientists are being listened to, public officials are being listened to. There is not this battle between politics on one side and science on the other side. I don't think a national mandate would work, but I think educating people about the importance of mask wearing would work. And mask wearing, Ed, I'll go this far. Mask wearing in certain situations as a mandate would work. For example, at the NYU medical complex, you have to wear a mask and you have to get a flu shot. If you don't get a flu shot, you have 2 weeks to think about it. And if you still don't want to get a flu shot, you're gone. And this is not just doctors and nurses. This is people working in advertising on Park Avenue for NYU Langone. It's a sense that we are all in this together as a medical institution, and we have to show basically what is right in that respect. So I think, yes, we could do this. You might need a mask to enter a restaurant, to this, but to me, it's become politicized to the point where we may be beyond the point of no return. I strongly support education in this respect.
So that's a segue into the next question, which is, Are there historical precedents for these sorts of things, these non-therapeutics becoming a political issue?
That's a very, very good question. I have never seen anything like that. In 1918, 1919, they actually enforced no spitting. They actually enforced mask wearing in New York City, and you did have to pay a fine. I've never looked to see whether, in fact, those fines were paid, but you did have police actually writing summonses. So I think that it's, to some degree, you can force this kind of conformity. Whether you can do it nationally, I think, is another issue. What I am hoping is that science begins to really sort of take the field again, like it was in February and March, and now it has faded out. I do think in small, NYU, basically, you have to wear a mask. And if you don't, there's a penalty to be paid. If you want to send your kid to school, Ed, as you well know, the kid has to be vaccinated against 5 or 6 things. Now, you're not going to arrest the child or arrest the parents, but the parents do have to pay a penalty. And that penalty is they cannot send their kid to public school. Those are other options that we can think about.
And so maybe for the last question, that it's just about that. So what are the ethical and legal implications of requiring vaccinations for COVID when it comes to employment or education?
That is really the $64 question. I sit on a number of these vaccine committees, and the idea of a mandate at this point seems a little far-fetched. But what I will tell you as an example, and tell the questioner as well, after a measles outbreak in Disneyland in California in 2015, some state legislatures were so angry that a disease that can easily be done away with a vaccine was being ignored, that a law was passed in California that did away with religious mandates, philosophical mandates. The only way you cannot have your child vaccinated in California today is if the child has a medical exemption. In other words, if a doctor says that the child is immunocompromised in some way, and therefore can't take a vaccine, then you will have a medical exemption, but there are no religious exemptions. And those are big deals, including in places like New York State. That has worked dramatically. The vaccination rate in California has gone up. And the penalty for those who still refuse to vaccinate their children, you can't send your kid to a daycare center. You can't send your kid to a private school. You can't send your kid to a public school. Basically, you have to homeschool the child. So that is a mandate that has worked, and other states, including New York State, have moved in that direction for vaccine mandates for children.
I want to thank everybody for these wonderful questions. Unfortunately, we can't get to all of them, but let's all join together and virtually clap for David Oshinsky. Thank you so much, David, for that really wonderful
I had a blast. I had a blast. I really thank you all for coming and listening.
Thank you, everybody. See you next time.
Yeah, thank you, Ed and David, for that wonderful presentation and conversation. So we invite everyone who joined us tonight to stay connected with the NYU Alumni Association and the Department of History on our websites and social media platforms, which you see here on this page. If you enjoyed tonight's program, we invite you to consider becoming a friend of the NYU History Department by the contact information in the chat, or emailing history.dept@nyu.edu, or making a gift to NYU at nyu.edu/giving. So thank you all for joining us. Thank you, David. Thank you, Ed, for that wonderful conversation and presentation, and have a wonderful rest of your evenings.